Welcome in, everybody, to another deep dive. This time, we're going to take a look at how psychiatrists are trained in psychotherapy during their residencies. It's a really fascinating area where we have these two kind of opposing forces at play. You know, the emphasis on biology and using medication,
Mm,
but then also this whole other world of talk therapy. And we're going to get an inside look at how that tension really plays out.
it really is such a fascinating dynamic. I mean, think about it, right? When we think of psychiatrists, we often picture, the prescribers of medication.
Right.
But more and more, they need to have expertise in psychotherapy as well.
Yeah, it's kind of
And
interesting.
that's really what we're going to try to unpack here. How do they reconcile those two approaches? What are the struggles and the successes?
Well, and we're starting off with a pretty bold statement. I mean, there's this quote from a really well-known psychiatrist, and he goes so far as to call psychoanalysis a plague on medicine.
Yeah, that statement gets right to the heart of this long-standing debate within psychiatry, doesn't it? Like, is mental illness fundamentally about the mind, or is it about the brain?
Mm.
And that question is sort of the foundation of our entire deep dive today. And it's a really tough hurdle, especially for residents. I mean, they're trained in that biological model,
Right.
but then all of a sudden they're expected to be competent in psychotherapy too.
It's almost like imagine you spend years becoming an expert in one field, and then all of a sudden someone tells you, oh, by the way, you have to master this totally different approach too.
Right.
That's going to be a huge challenge.
It is. It's a real shift. Our sources take us inside this residency program, Shorewood, to really show us how this plays out. And even though Shorewood is considered to be pretty progressive in their approach to training,
Okay.
they still struggle with balancing these competing ideas.
So even in a program that values psychotherapy, that pull toward the biological model is still really strong.
It is, yeah. And the way residency is structured, especially the early years, kind of pushes residents in that direction. Early on, they're mostly working with hospitalized patients. So
Mhm.
they're spending a lot of time learning about medications,
Makes sense.
how they work, how to manage side effects, that kind of thing. And one resident, Sandra, she actually describes a typical medication appointment, and it gives you a real sense of how ingrained this approach becomes in their everyday routine.
It sounds like it becomes just second nature.
It does, but here's the interesting thing, right? As they get really good at being prescribers, they also start to see the limitations of using just
Oh,
medication.
interesting.
They realize that it doesn't always solve everything.
Right?
And that's when they start to realize, okay, maybe I need these therapy skills after all.
That must be a pretty big realization for them.
It is. It's kind of a turning point. And it just so happens to coincide with a big shift in the whole field. You see, the ACGME, which is the organization that accredits residency programs, they now require residents to be competent in specific types of therapy.
Wow. So it's not even an option anymore.
Exactly. Yeah. It's like psychotherapy is now officially a core part of their training, and it forces them to really grapple with any doubts they might have about therapy and to actually develop those skills.
So let's dive into the world of psychotherapy a little bit.
Okay.
Our sources focus on two really different approaches, psychodynamic therapy and CBT.
Right. And those two, they're really great examples of just how diverse psychotherapy can be. Psychodynamic therapy, that's all about the unconscious mind, right?
Mhm.
It explores past experiences and how those might be affecting the person's behaviors and relationships in the present.
Yeah.
But CBT is much more focused on the here and now. It's about changing current thoughts and behaviors, and they often use really structured techniques.
And do they run into any problems trying to use these different therapies?
Oh, yeah. In fact, we see that happen with one resident, Sam. He had a really hard time trying to use CBT with a patient who just wasn't into it.
Sounds frustrating.
It was, yeah. But it shows you something really important about psychotherapy, which is that you have to be adaptable. No single approach is going to work for everyone, and therapists have to be able to adjust their techniques based on what each person needs and how they're responding.
So one of the terms that I thought was really interesting was epistemic friction. What exactly does that mean?
So epistemic friction, it's basically about the clash between different ways of knowing, different frameworks for understanding the world.
Okay.
In this case, it's the clash between the biological model, which is all about the brain and medication,
Right.
and the knowledge systems of psychotherapy, which are more focused on the mind, relationships, and those kinds of things.
So how does that clash play out for residents who've been trained mostly in that biological model?
It shows up in all sorts of ways, like they're taught to rely a lot on the DSM, the diagnostic manual,
Right.
to classify mental disorders. But when you're actually doing therapy, you often need a more nuanced understanding of the person, something that goes beyond just labeling them.
It's like you're trying to fit a square peg in a round hole.
Yeah, kinda. And then there's the whole issue of managing doubt, which is another thing that the source material talks about.
How so?
Well, in traditional medicine, you can often resolve doubt through tests or procedures, but in mental health, clinicians have to rely a lot on the patient's story, which can be subjective, it's open to interpretation,
Mm-hmm.
and that can be really tough for residents who are used to a more objective approach. It forces them to confront the limits of the scientific model when it comes to understanding something as complex as the human mind.
So how do they start to overcome their skepticism?
Yeah.
How do residents who come from this biological mindset begin to accept therapy?
One way is by turning to their instructors, those experienced therapists who've been there, done that.
Okay.
Residents, they really want practical advice, not just theory.
Right.
They want to know, okay, how do I actually do this? How do I structure a session? What do I do when a patient is resisting treatment?
Ah, so they want those concrete tools, those
Yeah.
strategies to help them bridge that gap between the ideas and actually putting them into practice.
Exactly. And another thing that helps is seeing those tangible results, those positive outcomes. When they witness firsthand how therapy can make a real difference in people's lives, well, that can be really persuasive.
It's proof in the pudding, right?
It lets them see the value of therapy beyond just the intellectual arguments. And then some residents, they actually use their medical knowledge to make sense of therapy.
Oh, interesting.
Like they might draw on their understanding of neurotransmitters or brain regions to understand how therapy could be influencing brain function.
So connecting what they already know to this new domain.
Yeah, they're making those connections, but it's not just the residents who are on this journey,
Yeah.
The instructors play a really important role too.
How so? I mean, how do those instructors help guide the residents through all of this? Especially when they're coming up against that skepticism from people who are so grounded in that biological model.
They have to legitimize psychotherapy in the eyes of their trainees.
Yeah.
They have to convince them that it's a valuable tool.
Okay.
And they do that by sharing research, case studies, really making the case for its effectiveness.
So it's evidence-based persuasion.
Exactly. And sometimes it even takes the form of these passionate defenses of their own therapeutic approaches. We see that with one instructor, Terry. He's really big on understanding the patient's humanity through psychodynamic therapy. He says psychiatrists shouldn't just be focused on the brain like computer programmers, but that they should be compassionate healers who connect with patients on a deeper level.
It's a good reminder that mental health care is about more than just treating symptoms, right? It's about seeing the whole person.
It is, and it's not just about knowledge, it's also about embodying a whole new way of being a doctor.
What do you mean by that? A new way of being a doctor?
Well, things like clinical case presentations and discussions become really important.
How so?
In those settings, residents have to start looking at patients through a different lens. It's not just about the medical stuff anymore. They have to
Mhm.
consider the psychological, social, and relational aspects of their patients' lives, too.
So it's about widening that perspective to really see the whole person.
Exactly. Like, we see this with one resident, Jacob. He really struggled at first to move beyond that medical training when he was presenting a case.
Okay.
He could do it from a medical standpoint, no problem, but he couldn't figure out how to incorporate a psychodynamic understanding.
It sounds like learning a whole new language almost, right?
It is, and a really important part of this process is self-reflection.
Okay.
Residents are encouraged to think about their own thoughts and feelings and how those might be influencing how they interact with patients.
So acknowledging that the therapist is a part of that relationship, not just an observer.
Exactly. One resident, Lucas, he had this realization about how important it was to consider his own emotions in that therapeutic relationship. And it gets at something really key, which is how complex those therapeutic relationships can be. But what's interesting is that some residents, they're able to embrace both of these approaches. They find ways to bring together the biological and the psychotherapeutic in their practice.
That's that idea of a hybrid repertoire, right?
Mhm.
Where residents are successfully blending both viewpoints in their work.
It is, and these residents are really impressive. They're showing that you don't have to choose one side over the other. Like there's Vinit, for example. He used psychodynamic ideas to actually improve how he was managing medications.
Interesting. So it's not just about prescribing pills.
No, he's using his understanding of the patient's psychology and relationships to make more informed decisions.
That's fascinating.
It is. He's a great example of how powerful integration can be. And it suggests that there's this potential for psychiatry to move in a direction where these two approaches, they're not seen as separate anymore, but as complementary.
That's a really compelling idea.
Yeah.
But as we've seen, it's not without its challenges.
No, it's not. I mean, changing how we think and how we practice, it's never easy. And these residents, they've spent years learning that medical model.
Right.
So moving to a more holistic approach, that requires a lot of flexibility.
A willingness to shift your perspective.
Exactly. And we have to remember that skepticism, it's not always a bad thing. In fact, it can be really valuable in science and medicine.
How so?
Well, a healthy amount of skepticism can actually push you to think more critically, to question assumptions.
Okay.
And in the end, it can lead to a deeper, more nuanced understanding. And our sources, they talk about how productive skepticism can actually help with integration.
Interesting.
You know, it encourages residents to really engage in that internal debate, to weigh the evidence, to consider different viewpoints, and to ultimately arrive at a more sophisticated understanding of mental health care. It's a journey, both intellectually and professionally.
Sounds like it.
And this whole idea of wrestling with different knowledge systems, that's not just relevant to psychiatry or psychotherapy, you know?
It goes beyond that.
Yeah, it gets at the heart of what it means to have knowledge and expertise in any field.
So how do our sources approach that broader idea of knowledge and expertise?
They argue that expertise is not just about knowing a lot of facts or being really good at certain skills.
Okay.
It's also about having a particular way of seeing the world.
Like looking through a specialized lens.
Exactly. And what these residents are learning to do is to put on those psychotherapy glasses,
That's a great analogy.
to start to perceive mental health through a different lens. And it's not just about adopting a new perspective, it's about learning how to move between these different knowledge systems, understanding where they overlap, where they diverge, and how they might complement one another. And that brings up a really important question.
Yep.
What does all of this mean for the future of mental health care?
That's the million-dollar question, right?
Hi.
What did our deep dive reveal?
It seems like this tension between the biological and the psychotherapeutic, it's probably going to continue to be a major force in the field.
So it's not going away anytime soon.
Probably not. But it's not about one approach winning over the other.
Right.
It's about finding ways to integrate them, to create a more holistic approach that recognizes just how complex the human mind really is.
And it sounds like residency training is a crucial part of that evolution.
It is, by exposing residents to both approaches, you know, by encouraging them to grapple with that skepticism. Residency programs are really shaping the next generation of mental health professionals.
They're equipping them to handle these complex issues.
Exactly. They're giving them the tools to provide more comprehensive and effective care. And our sources also talk about how impactful that ACGME mandate has been on residency programs.
That mandate requiring competency in specific therapies.
Right. It's basically elevated the status of psychotherapy within psychiatry. It's not just an extra thing anymore. It's core.
It's essential.
And that shift, it's not just happening in residency training, it's happening across the entire field. We're seeing more and more people recognize the importance of psychotherapy in treating mental illness. There's a bigger focus on integrated care models that combine medication and therapy, and there's even a renewed interest in understanding how the mind and body interact.
So this integration, blending the best of the biological and the psychotherapeutic, that has a lot of potential.
It does. But our deep dive also uncovered some of the challenges of actually making that happen.
Like what?
One thing they talked about was the structural limitations in residency programs and even in the healthcare system as a whole.
Okay.
Like, even though the ACGME says residents need to be competent in therapy,
Right.
they still spend a ton of time on pharmacology.
So there's a disconnect between what's required and how they're actually being trained.
Yeah, exactly.
Oh.
Early on, the focus is still very much on that biological approach, which makes it even harder to switch over to psychotherapy. It's like there's this resistance to change.
A kind of inertia in the system.
Yeah, exactly. And that's made even worse by the realities of mental health care.
In what way?
Well, a lot of psychiatrists are under pressure to see a lot of patients in short appointments,
Right.
which means there's just not a lot of time for therapy.
So the system itself creates these barriers to a more integrated approach.
It does. And this push to focus on meds over therapy, that also reflects how society views mental illness.
That makes
There's
sense.
still so much stigma,
Right.
and that stigma often leads people to want quick fixes, to shy away from the longer, more emotionally challenging work of therapy.
So it's this complex web of factors, right?
It is.
You've got historical trends within psychiatry,
Mm.
economic constraints, societal biases, and then the structure of the healthcare system itself.
Yeah, it's all connected. And it reminds us that change, especially in a field as complicated as mental health care, it takes time, it takes effort, it takes a lot of different people working together.
It's not going to happen overnight.
No, it's not.
Yeah.
And it reinforces that mental health is not just an individual issue, it's a collective one. Right. And the way we train mental health professionals, well, that reflects our values and our beliefs about mental illness as a society.
So we're back to that central tension that we've been talking about.
Yeah.
The tension between that biological approach focused on the brain and meds
Mm-hmm.
and the psychotherapeutic approach,
Mm-hmm.
which is all about the mind, relationships, and lived experiences.
It's a tension that's probably not going to go away, but maybe it's not about getting rid of it. Maybe it's about finding a way to live with it.
To embrace it.
Yeah, to see it as part of the complexity of the field. And it's through that ongoing negotiation, that back and forth between different perspectives, that we can really move forward and develop more effective and compassionate care.
It seems like a big takeaway here is the importance of not just knowledge, but wisdom.
That's a really good point. And the sources talk a lot about how self-reflection is key to developing wisdom. It's about being able to step back and really examine your own assumptions and biases. It's about recognizing that practicing mental health care, it's about more than just techniques or protocols.
It's about how you approach it.
It is. It's about cultivating a certain mindset, a way of being that's rooted in empathy and curiosity and a deep respect for the human experience.
That makes sense.
And it's about recognizing that every patient's journey is unique, that healing is not a straight line. It's about being comfortable with uncertainty.
With not having all the answers.
Exactly. It's about being open to learning from your patients, from your colleagues, and even from your own mistakes.
Okay, so as we wrap up our deep dive into the world of psychiatry residency, let's take a minute to recap what we've learned. We've talked about this constant tension between the biological and the psychotherapeutic approaches to mental health. We've heard about the challenges that residents face trying to reconcile those different ways of thinking, and we've gotten a glimpse into this really complex and evolving landscape of mental health care. So where do we go from here?
Well, let's break down those key takeaways for our listeners, give them some real food for thought.
Sounds good. What are those essential truths that we want them to walk away with?
First and foremost, I think it's crucial to remember that psychiatry is inherently a field with this dual focus, right? It's always trying to balance these biological and psychotherapeutic approaches. And that balancing act is shaped by so many factors, history, science, societal attitudes, even the structure of our healthcare system.
And that brings us to our second takeaway, which is the impact of residency training. Those early years really emphasize the biological model.
Yeah.
Residents spend so much time immersed in medication management that it can make the transition to psychotherapy that much more challenging. It requires a real shift in perspective, a willingness to learn new things and to question what you already believe.
Absolutely. And our third point builds on that. We're seeing this rise of psychotherapy within the field, right? The ACGME now requires residents to be competent in specific therapies, which shows just how important psychotherapy has become. And it forces residents to confront any skepticism they might have and to really develop those skills.
And we can't forget about epistemic friction, which was our fourth key takeaway. That clash between different ways of knowing, between the biological and the psychotherapeutic, it creates unique challenges for residents. It forces them to think differently, to adapt their clinical practices, to grapple with uncertainty. And ultimately, it helps them develop a more nuanced understanding of mental illness and how to treat it.
For sure. And speaking of grappling with uncertainty, our fifth takeaway highlights the crucial role that instructors play. Those experienced therapists are like mentors. They guide the residents, they validate psychotherapy, and they help them overcome their doubts. They're not just teaching information, they're modeling a way of being a mental health professional that values both science and human connection.
And that brings us to our sixth point, which is the power of self-reflection. Learning therapy involves a lot of looking inward. It requires residents to examine their own thoughts, feelings, biases, and to really understand how those internal dynamics might be affecting their work with patients.
It's about recognizing that the therapist is not this neutral observer, they're part of the relationship, and their own experiences matter. And, some residents, they actually manage to embrace both of these approaches, which is our seventh takeaway. They develop what the sources call hybrid repertoires. They find ways to blend the biological and the psychotherapeutic in their practice.
So they're showing us that it's possible to create this more holistic and personalized approach to treatment.
Exactly. They're bridging that divide, taking the best from both worlds, and showing that you don't necessarily have to choose one over the other.
But we also learned that this path toward integration is not always easy. And that brings us to our eighth takeaway, which is that a healthy dose of skepticism can actually be a good thing. It pushes you to think critically, to weigh the evidence, to question what you think you know. And in the end, it can lead to a much richer understanding of both the biological and the psychotherapeutic.
Couldn't agree more. And our ninth takeaway emphasizes that becoming a skilled mental health professional, it's about more than just knowing the science or mastering certain techniques. It's about developing this ability to connect with patients on a human level, to build those therapeutic relationships, to be comfortable with uncertainty, and to accept that the human mind is a complex and often ambiguous thing.
It's about recognizing that mental health care is not just about protocols and prescriptions. It's about cultivating a certain way of being, one that's grounded in empathy, respect, and a genuine desire to understand another person's experience.
Beautifully put. And so our 10th and final takeaway is this. By understanding the tensions, the challenges, the successes, and the ongoing evolution within psychiatry, we can all develop a more informed and compassionate view of mental health care. It helps us advocate for better treatment approaches, to fight stigma, and to support those who are struggling.
It's about recognizing the complexity and humanity of mental health. And as we wrap up our deep dive today, we want to leave our listeners with one final question to consider. What are the potential consequences of this ongoing struggle within psychiatry to reconcile its dual focus? What possibilities emerge when we embrace both the biological and the psychotherapeutic? And how can we work together to create a future for mental health care that honors the multifaceted nature of the human experience? Thanks for joining us for another deep dive. Until next time.